Starting on October 1st of 2015, the new ICD-10 codes are going to be used to describe diseases, signs and symptoms, abnormal findings, complaints, social circumstances, and external causes of injury or diseases. All insurance carriers, including Medicare, Medicaid, and private insurers, use ICD codes to write medical policy and determine whether or not a claim is payable. Billing staff use the PCR, patient care report, or known as the run report for ambulance services to determine what ICD-10 codes to report on a claim. There's a small set of codes and condition codes used for EMS billing as compared to physicians. Once the ICD-10 transition is complete, the specificity of crew documentation will be of the utmost importance when the billing staff is preparing to code a claim. The transition will be difficult for billers and clinicians alike. When the billing staff is selecting a code to report an injury to the elbow, forearm, or wrist, there is one code they are likely to use now. On October 1st, they will have many more specific codes and choices to make. The current ICD-9 code, specifically for an unspecified injury of the elbow, forearm, and wrist, is just one code. However, with the new ICD-10 code, it shows 6-7 different ones, like other specified injuries, unspecified elbow, initial encounter, and you can go through there and read how each code is going to be explained using a specific number. You'll see down towards the bottom here the other specified injuries of unspecified wrist, hand, and fingers initial encounter, or unspecified injury of unspecified wrist, hand, and fingers initial encounters. This is going to be important for the biller to use the right code so we can get the maximum reimbursement so claims don't get denied or whatever, sent back or just denied in full. This is going to be up to how you as an EMT document your services on the run report. Remember, while you don't code, the description of your care on the run report is what the billing staff uses to code accurately and for the best reimbursement for the run. You must notate the detailed information shown above and for all situations as well. Note specifics for every situation. If you use an unspecified, we could get reimbursement at a lesser amount. Be specific: right elbow, right hand, thumb, partial amputation, etc. You must be specific as locations and for all injuries and health related stuff, such as a pain in the stomach. Where is it coming from? What is it, how is it reflecting itself to the patient? Let's take a closer look at two last codes, the X and the placeholder in a code set. This allows the billing staff to assign a code for the injury to a high level of specificity. Left hand, left right finger, severe injury. If there are multiple fingers involved, the billing staff could have dozens of codes to choose from. If the documentation is not specific, coding this injury becomes virtually impossible and unbillable. Next to patient care, good documentation is one of the most important parts of an EMT's job. Most EMT providers don't fully appreciate the many uses for their documentation. A greater appreciation of the importance of accurate and complete documentation comes from the better understanding of its uses and applications in critical areas of an organization's overall operations: clinical, reimbursement, and compliance. Clinical, let the record reflect. First and foremost, documentation serves as vital clinical purpose. A copy of the PCR is given to the receiving facility for continuity of care. It communicates to the provider what treatment the patient has received by the ambulance server. The PCR should accurately and adequately document the care provided to the patient while in your care. It becomes part of the patient's medical record here and at the receiving facility. In the digital age, that record likely follows the patient everywhere they go. A complete and accurate record is important. Reimbursement, show the money. Documentation plays a vital role in reimbursement. If your organization is plagued with poor documentation, which ours is sometimes and very often, can be in poor health for the ambulance service. An organization's overall financial health can be quickly determined with a quick set of vital signs, just like your patients. Take a quick look at the profit margins. Is your company profitable? What financial condition is your company in? Good, fair, stable, serious, or critical? If there are no margins, there is no mission. It's really that simple. Your organization's survival depends on its ability to secure reimbursement. Compliance, we're watching you. Compliance is one of the most important elements of the billing process. There are regulations that dictate that which elements are required before a claim can be billed. The billing staff must review the documentation and determine if what is contained in the record meets the state and federal regulations before a bill can be rendered to an insurance carrier. Aside from the PCR, there are other requirements, PCS forms, which we don't have to worry about here with RAS because we don't do non-emergency billing, and also things like the ABN forms. But the signatures and surrogate signatures are very, very important. Before a claim can be coded and filed to insurance, the billing staff must determine if the PCR is complete and accurate. If not, it must be returned for addenda or additional clarification. An intubated patient who has been administered paralytics and sedatives should not have a GCS of 15. So what this is all saying is that if you don't have enough room on the initial run report, please, please, please start taking the time to add addenda. Take another piece of paper, fill out more completely what you're trying to say. Use another run report and fill that in where you need to add more documentation. But when you do this, please make sure that you, on your initial run report, you notate what to look for on the addenda. And then in the addenda, also use the run report number, the date of service, the patient's name, your name, and then relate it back and put that information into the run report. So make sure no matter which piece of paper they pick up, that they'll be able to track what they want to see. Insignificant, never. Mileage documentation for start, arrival, departure from scene, and arrival at hospital are a must. This is where we are very, very bad in notating this stuff. Protocol must be established to document all these times. Dates are also in the list. Please see the attached run report for all necessary information, and that does mean all. Remember, the chief, your document people, are going to have to set up protocols that must be followed in getting this information. If we are audited and somebody, EMTA, has not been consistent in reporting their information, the agency that's doing the investigation will go back to our protocols and say, oh, well, then A is the one responsible because the protocols say that they should have been doing this, this, and this. If there are no protocols, then the service as a whole is going to be held responsible. So if we must get protocols in place, we must get those protocols to make whoever is on the run, no matter what that person is doing, if they're just the driver or whatever, you have to have each other's back. So again, I'm going to repeat myself. We must get those protocols in set, and then people who are out on the runs must start following those protocols. Here are some tips for documentation of emergency transport. How were you dispatched? What were you dispatched for? What did you find once on the scene? What were the events leading up to the injury or illness? Why does the patient require an ambulance? Is transport by other means contraindicated? Why? What interventions during transport? Why transported to a receiving facility? What specific service required? If not the closest appropriate facility, why? And again, we don't use ABNs. This information is a must to have, and it must be thorough, because you may leave the ambulance garage and on the way to there you may have an accident before you even get to the patient. If you do, then we need that stuff for what is going to probably inevitably be legal intervention on either your part, for you, against you, or against the service, or for the service, or against a third party that was involved in the accident. If it was our fault that caused the accident or their fault that caused the accident. We need this information right from the beginning, that you have it documented. And then once you get there, fill in all this other information as its responsibility is necessary to have this information for further things other than just the treatment of the patient. Things that should never be in your documentation. Never make assumptions, like never document patient is intoxicated. Stick with observations such as patient smells of ETOH. Never assume an injury is self-inflicted unless the patient tells you. Even if the patient tells you it's self-inflicted, it does not serve a vital clinical purpose, diminish the patient condition, or change the way you treat the patient. However, it may block the ability to be paid when documented. Again, this is going to be described in our protocols, so that's what we're going to look to our chief and protocol officer to institute this. Never document a diagnosis unless the patient has diagnosed by a physician. Like, do not list primary impression as MI, CVA, fracture, etc. in the field. Never use unapproved abbreviations, NGS, TMB, UTS, PUTS, etc. Misspelled words, use your spell check. Never sign the consent form for your patient. We have specific protocols on this. Never alter the PC, and again, we don't use the PC. Oh, I'm sorry, we do. I was thinking of the ABN. Never alter the PCS form in any way, shape, or form or fashion. The most important part of a PCR is the narrative. This section contains the information billers and claim processors can wrap their minds around and really understand. Narrative should outline how and why the crew was dispatched, contain how the patient was found, and pertinent negatives describe the scene and outline the events leading up to the time they arrived. Remember, without proper documentation and the abilities to secure and reimbursement, your organization may not survive the ICD-10 transition. Engage your billing, clinical, and education staff to come together and make changes now to help ease the pain of this transition. Specific documentation subjects that occur frequently. CDI programs assist organizations and providers by supporting a standard of clear and complete documentation in the health record at the time of discharge. The program can be tailored to meet the needs of the organization or provider and require strong collaborative teams. The best place to start is by analyzing current high-volume services, MSDRGs, or claims. These are specific documentation issues today that are problematic, which may continue through to ICD-10. And areas that CDI specialists may want to review and prepare for are acute myocardial infarction, asthma, cerebrovascular disease, coma, diabetes, fracture, orthopedics, pregnancy, pressure ulcer, respiratory failure. Documenting acute myocardial infarction. The terms acute myocardial infarction is somewhat nonspecific. Go ahead and read this information as we go through. Documentation tips. Focus clinical documentation on identifying the date of the onset of the MI and duration from onset of MI, along with the type, anatomic location, and consequences of the MI. Documenting asthma combines ICD-10 combines intrinsic or extrinsic asthma into one category, so specialists will no longer need to identify these conditions. I'll let you go ahead and read the rest of this paragraph. The documentation tips focus clinical documentation on the severity of asthma and relationship to other diseases when applicable. Documenting cerebrovascular disease. I'll let you go ahead and read this. Documentation tip. Focus documentation on the specific type of hemorrhage or infraction, artery affected, and the laterality. Providers can also specify occlusions or stenosis to an artery and laterally. So what this is saying, I don't expect you to know these codes. You don't need to know these codes. But what I need from you is when you document this stuff that you start using the language that our coders and billers can go in and understand completely what you're talking about. Documenting a coma. I'm going to let you read that. Documentation tips for trauma centers. This documentation will be found in the emergency department and or trauma record. It can also be found on ambulance run sheets. Focus documentation on ensuring that all components of the GSC scale are completed and that the 7th digit accurately reflects what the scale was related to. What this is saying is when you record your GSC scale, make sure that they're completed completely and fill in everything and note everything that is necessary in the process of getting that GSC scale. Documenting diabetes. I'll go ahead and let you read that. Now, again, I'm not asking you to know these codes or anything. I just want you to kind of see by reading this what they are looking at when they're trying to code and bill. That's why it's so important that you document stuff so they have an actual and a correct view of what you saw so they can code it. The documentation tips. Focus documentation on the type of etiology of diabetes, body system affected, and any complications affecting that body system. Documenting fractures and orthopedics. Again, this is getting down to where the locations are and all that other information. I'll leave that up there just a second for you, but I'll keep talking. The documentation tips is focus documentation efforts on fracture type, laterally, and the type of encounter. Review the radiology reports, which you won't have at this point, but just make sure that you're showing exactly what you see in a fracture or an orthopedic problem. Pregnancy. I'll let you go ahead and read that information while I comment also. Focus on documentation on trimester and number of weeks counted from the first day of the last menstrual period. In cases of multiple gestations where complications affect one or more of the fetuses, identify the fetus for which a complication occurred when possible. Again, give as much information on the pregnancy that you can get from the mother, and so all that information is listed in the report, so you can make an accurate determination as to the care that you need to be given, and then document that care. Documenting pressure ulcers. Again, this information, I'm going to let you read it. And then the documentation tip is focus documentation on specific ulcer documentation, such as the site, laterality, and stage. Reporting extensive ulcers may require multiple codes or a single code for certain contagious sites as found in the index. So again, be very specific and look at the whole picture so you get as much information in there as necessary. Respiratory failure. I'll let you read that. The documentation tip is focus documentation on acute, chronic, or acute on chronic respiratory failure, along with hypoxemia or hypercapnia. As you can tell, I'm not a medical person. I just build this stuff. So we'll go on from there. CDI pays the way for ICD-10 success. Again, this is just kind of a comparison here of the old code that we had for atrial fibrillation. Now the new codes, we have this breakdown, and we're not going to get paid unless you guys really code as accurately as you can when you see some of this stuff, if you know what's going on. If you don't and run into situations, perhaps the service needs to do some classes in what they're seeing or what the EMT is seeing and how that reflects in on how they can document that information so we can get the best information and reimbursement possible. Now, of course, at any time, you guys can go back and relook at this and stop it at a certain point and review stuff if I'm going a little too fast. So now we're going to go into the actual run sheets. On page 1 of the run sheet, very few fields on this page should be omitted. The more complete the report is filled out will result in better reimbursement for RAS. Missing information can lead RAS being fined by state and/or federal agencies. Information will be necessary by you, attorneys, and/or other litigants if you are called to be a witness in court due to a lawsuit either by or for a patient, hospital, or regulatory agency. The boxes in blue on the form that I'll show you are necessary only if the run relates to that particular box. Those blue boxes are the dispatch notified, the unit dispatched, unit canceled, MCI for mass casualty incident, factors affecting care, patient physician, ask the patient or family member if they don't know it. Guardian, this is absolutely necessary if the patient is younger than 18, preferably 21, because a lot of policies now cover children even older than that. And also try to get the guardian's address, phone number, and medical information, and any other information that you can get would be very good. A lot of times you can get this information if there's a police officer or firefighter on location. They're more than glad to help you usually once they're done with their job. Race and ethnicity. The boxes in red are always necessary unless absolutely not relevant to the particular run. Again, we've had many, many instances where these fields are not being filled out. With ICD-10 and the legal ramifications and the fines we can get for this stuff not being completed are really putting the service at jeopardy. So these fields must be completed if they are relating to the service that you're doing. For more information required, you must get it from the patient. You or another RAS member can try to get the information from the patient. Family members, friends, police fighters, or hospital personnel are also possible sources to be able to complete your PCR. And again, most of the hospitals we serve have been very good at getting the information that we need from their inflow sheet. So please, please keep asking for that. So here's page 1, and as you can see, you see a lot of red. This is stuff that we are consistently missing sometimes, and the red is actually the stuff that we must have. And there's so much stuff on here that all the EMTs are not good at getting filled in. First of all, you need the call time for the PSAP call. If the dispatch is notified or the unit dispatched, you can fill this in. This is not necessary unless it's needed. The start time that you begin en route. Arrive at the scene. Arrive at the patient. Leave the scene and arrive at your destination, which is the hospital or emergency room. What time you went into service. If the unit was canceled. In quarters. That's not necessary unless we set up protocols for that. The PCR number is this number here, so it's automatically filled in. You don't need to worry about that field. The number of patients, that's the number of patients in the ambulance. If you go to a car wreck and you're taking care of one and our other ambulance or another ambulance service is taking care of another one, you only put one in here because you're only going to have one in transport. If you have the mother and a sick and an injured child, then it would be 2. If the mother and the child are both injured and you're giving care for both. Mark this is the mass casualty infield at the scene mileage. So we're going to have our starting mileage when you pull out of the garage, at the scene mileage, your destination mileage, which is at the ER and stuff, and your ending mileage. These mileages are not complete on the majority of our forms. You've got to start documenting, and it's got to be a joint effort between the driver and the EMT or the multiple EMTs that are on the scene. You all have to be responsible for this. The attendants, this is the attendants that are attending to the people, your first responders, and then the drivers here you want to list to the scene, to the destination. If they, like if, for example, Diane was the driver, was she the driver to the scene, but then she took over as caring, and then somebody else met her at the scene and became the driver at that point, so on and whatever. First responder agencies. Put the first responder's name here. It should also go up here though if any of this stuff needs to be found completed. Incident address. This is the incident where the actual incident happened. If it's somebody's house, then it's their house address. If it's downtown at the grocery store, you put the address of the grocery store. Then fill that. This is the information for the scene. You need to start filling in the type of location where it is. This is important, especially in lawsuits and stuff. Response request. We need this information found out. Again, lights and sirens, no lights. This stuff has to be completed, because if you're in an accident before you get there, it's going to be very important if we're sued or we need to sue somebody else or whatever the situation. And the reason I keep stressing suits so much is because this can put us out of business. This can make us lose our licensure. We've got to start getting this stuff because we have one instance. It can put an end to RAS immediately. So this is very important to the service. So make sure all these are filled out every time. Now, this is the patient information. This is the person that you're actually taking care of, that you're giving service to. This information all needs to be completed. You don't hit some and miss others. If they don't give you something, then of course you can't. But you should note somewhere in the notes then that you asked for or whatever and it was not given to you. You need to fill this information in and be very, very complete. We absolutely must try to get the date of birth. We must try to get the Social Security number, if at all possible. Don't always just take, especially out-of-town individuals or people that are maybe intoxicated or whatever. Try to see copies of stuff, because so many times we are given a number and then we go to look up and try to find them and we can't because the number is for somebody else. So try to be very diligent in how and where and why you get that information. Patient physician. It's good to know who the physician is, so this information can be related to them if necessary. Again, for a child, if they're under 18, you must get this information. Along with that, then also try to get their address, their insurance, and stuff like that. It's true, the guardian may have one insurance, but the child may have some other insurance or whatever. But you must get that, and again, make that in your notes or an addendum that you add this information. If it's a guardian, try to get as much of this information on them as also. Again, the race and ethnicity, we need to try to get that because it is used for documentation and stuff by agencies. Prior aid and stuff, this is very important. So if it relates to your run, please fill it out. I guess what I'm saying and pushing for is read every box. So many times we get in, I know even with my job, I do it so many times, I just kind of blank, blank, blank here. We've got to really start watching these boxes and making sure that each box that is relevant to this run is being filled out. And basically the only way you can do it is go box by box. Again, factors affecting the care, that can be filled out. This is where you're going to: Grand Rapids ER, Deer River ER, Crosby, Arlington, whatever. That needs to be filled out. Destination, we need this filled out, especially Oh, well, not especially, but we need that filled out. And if it's too like Brainerd or something, that's out of our service area. So it becomes very iffy if we're going to be reimbursed for that because of the fact that they're out of our service area. So we need to know why that we were taken out somewhere else and who made that decision. Destination type, we need that filled out. You might say Grand Rapids ER here, but that doesn't play when you're in court or something. They'll say, well, you didn't say that. You know, it's a different box, different reason. They'll find race. So we need to get this stuff completed. Again, primary route of unit, role of unit, dispatch reasons and stuff like that. When we get a reason, why were we dispatched? Then down here we have the provider impressions. Fill out this completely. Again, these areas here are so many times not checked and they need to be completed. As we move on to page 2, almost no fields on this page should be omitted. The more complete the report is filled out will result in better reimbursement for the RAS. This health-related information is very important in the outcome of some circumstances that it can occur. We have above or will discuss below. Missing information can lead RAS to being fined by state and or federal agencies. Information will be necessary by you, attorneys and or litigants, if you are called to be a witness in court to do a lawsuit either by or for a patient, hospital, or regulatory agency. You notice there are no blue boxes. All information is necessary and important if it relates to the run, even if you don't think so. If you can answer the box with the information that you have, then you need to do it. If you don't answer it, then you need to make a notation in the notes as to why you didn't. You should get into the habit of looking at each box for each run. Don't assume you remember what is relevant or not for a particular run. This page is probably the page that has the most missing information for its relevance in obtaining necessary information for the patient's health as well as reimbursement and legal issues. For information required you must get from the patient, you or another RAS member can try to get from the patient. Family members, friends, police, firefighters, or hospital personnel are also possible sources to be able to complete your PCR. Every field should be completed. Very seldom is a field completely irrelevant. The cause of injury and its description contributes to more knowledge in billing and showing information necessary for further uses. Documenting and asking about medications being taken, allergies, surgeries, all contribute to the biller being able to code for better reimbursement. You'd be surprised at the number of times something is said and I don't really understand what was going on in the notation, but I see that they were given a certain drug or something and I know what that drug is for. By putting that connection, then I could, oh, well, the reason they had this done was then because they had this disease or they were being treated for such and such. I can make those determinations with that information as long as it's in the report. So be good about getting it. Remember to document, document, document due to the rules and the new ICD-10 coding coming on October 1st, 2015. Please start documenting your accuracy and completing the run sheets now so that our billing service can let us know issues that they may see before it is mandatory and could affect our reimbursement. So again, here is our page 2. You see that the whole page is circled in red. You need to start filling in every one of these fields unless it is absolutely not relevant to the patient's pickup, care, or transport. Some of these are asking information that may be somewhere else also, but just because it was mentioned somewhere else or you wrote it down in the commentary does not mean that you do not fill this in. You must start filling in all of these boxes if it happened or is relevant to that particular run. I just highlighted some of these other boxes just so you can see that those are really, and I hate to use the term more important, but make sure that you get them filled in. Again, I'm not putting insignificance into any other field. You must take care in making sure that each field is filled out. Down here at the bottom, complete all columns and a separate line for each and every occurrence. You'll notice here what I see a lot of times. I'll see stuff put in here and then something put here but no time, and then something. You need, when you put something on a line, you need to put it there and fill out the whole thing as it relates to that service. If you're going to take pulse and you take the blood, the SpO2 levels and stuff, like all this stuff at one time, then put that all in there at one time. But the next time down here, let's just say you check the blood pressure, you need to make sure that you put the time in for that, what you're doing, and fill out all this other information that's relevant to just taking the blood pressure. If you're given a drug, then that must be put on another line, unless it's put in with another line where you did something else. But if it's too convoluted or whatever, by putting everything on one line even though you did it all at once, then break those lines apart. And again, always feel free to use a second run sheet or addendum. So document, document, document. Do not skip a field. There's usually does not apply or no or something in the field that tells you that it wasn't necessary on this page and others. For example, like you got none or not at all, none, none. So you need to check those. If it's none, then check none. Page 3. Again, almost no fields on page 3 should be omitted. The more complete the report is filled out, will result in better reimbursement for RAS. This health-related information is very important in the outcome of some circumstances that can occur when we are all above or we'll discuss below. Missing information can lead RAS to being fined by state and or federal agencies. Information will be necessary by you, attorneys, and or other litigants if you are called to be a witness in a court due to a lawsuit, either by or for a patient, hospital, or regulatory agency. Again, you notice there are no blue boxes. All information is necessary and important if it relates to the run, even if you don't think so. The whole page is outlined in red, and all fields are always necessary unless absolutely not relevant to the particular run. I have also outlined in red the individual fields that are most likely always necessary for complete and extra notation. You should get into the habit of looking at each box for each run. Don't assume you remember what is relevant or not from a particular run. This page is probably the page that is most for documenting the person's actual health at the time and during transport. Again, this information is important for its relevance in documenting the patient's health as well as for reimbursement and legal issues. For more information required you must get from the patient, you or another RAS member can try to get it from the patient. Family members, friends, police, firefighters, or hospital personnel are also possible sources to get the information so you can complete your PCR. Every field again should be completed. Very seldom is a field completely irrelevant. The cause of injury and its description contribute to more knowledge in billing and showing information necessary for further uses. Documenting and asking about medications being taken, allergies, surgeries, and all contribute to the biller being able to code for better reimbursement. On this page, it is especially important to remember to document, document, document. This is where you can be very detailed in listing every location: hand, finger, elbow, upper leg, lower leg, ankle, foot, toes, left, right, etc. Always remember, can I give more information than I have already given? Also, there is a box that I have circled in the red at the bottom that says continued on supplement. That can be another run sheet, and if you do, note the numbers on both on each, or a separate piece of paper noting patient's name, date of service, run sheet, etc. to track back to each other. Again, if a service is offered or the patient was checked for any of the information that should be recorded in these sections, please notate. Remember, document, document, document. If the box isn't relevant, again, in most of these boxes, it gives you a no or not necessary, or, for example, cardiac arrest, no, yes, It's in there. There should not be a box, hardly ever, that is not filled in. And we've got to start doing this. Patient past medical history. This is very important for proper coding, can drastically affect reimbursement dollars. Remember, a lot of times with what is in there, we've been able to take and figure out that we can bill for something because what we have seen as knowledgeable billers is that this relationship here did have a relationship on what you're perhaps describing down here. And maybe you don't realize that. So that's why we need this information. And again, document, document, document. Remember, new ICD-9 or it's so hard to quit saying that. ICD-10 coding requirements. Right hand, index finger, etc. Be very specific on location and type of medical or alert. If they've hurt their head, what side of the head, what's it show, is there a contusion? List everything. If it's a face injury, what's injured? Is it the cheek? Is it the nose? Is it the left eye, the right eye? Left nostril, right nostril. You got to be very, very specific moving forward. For every agency or accident, make sure this is filled out. So if there was a car accident, this is the airbag deployment. If you don't happen to know, then you need to talk to the officer if they're there at the scene, or maybe somebody that's seen the wreck or something. If nothing is available, then note that in your notes. Was not able to see car. Patient was found at such and such. Down here for the safety equipment, remember responding equipment will probably help in getting this information. Or your police officer or whatever, child restraints and stuff like that. We need to know that stuff. If there was, especially like for child restraint, if it was a child, if they're like working at work and they have an eye injury, what did they have? Eye protection. Not even you don't fill this out just because there was or was not an eye injury. If it was work related specifically, though, that's where this usually kicks in for something for this particular question. But were they wearing eye protection? Even if they were in a regular wreck, did they have eyeglasses on and stuff? You'd want to notate that stuff. Again, you want to get the receiving RN or MD at the hospital. This is required. The guardian signature can go here if it's a child. A lot of times we see the guardian name on the front page, but we don't see the guardian name here. You need to fill that out if there's one, if the person is there, or whoever's watching the child or whatever. Refuse transport. If somebody refuses transport, we need to get this signature here. Follow the guidelines that are on our signature sheet, but this should be signed also. Technician, which is yourself. And then down here is the continued on supplemental. If you're going to use a second run report, you'll check on that, check that, or if you use an addendum, you've just typed out on a piece of paper. But again, when you use other notation, like another run report or an addendum on a piece of paper, make sure you put this run sheet number, the patient name, date of service on that other addendum, or and then you relate in the addendum back to what this number was and stuff. If you're using a run sheet, co-reference the two run sheet numbers between each other so that they're able to be tracked. So this is the information on using the run sheets. We've got to get a lot better at filling this stuff out. So this hopefully will help you in being able to determine what we're asking. And again, there's not a field on here that you should be missing unless it's completely not relevant. If it's not relevant and there's a no or whatever on there, then you need to check the no or whatever. So we got the first page, our second page, and then also our third page. And again, if your writing isn't good or something you miss after the fact, you get back to the building, use your addendums to complete information that you might not have had time to do at that point. Rack your brain because you need to fill these out and completely. So if you have any questions, go to your chief and follow your protocols, and hopefully we'll have a better reimbursement and prevent any further comebacks from our payers or anything like that, the agencies, and be able to help the service financially.